social initiatives at the Apollo hospitals. She has developed interest in lean methodology and patient safety. She's been a guide at Apollo hospitals wherein we talk about all the patient safety initiatives. Welcome, ma'am. To join them, we have the speakers here. Now I may call upon on stage Professor Cliff Huggs. I think we can clap louder. The next eminent speaker among us is Dr. Peter Lackman. It's going to be even more louder. We need to tell them what India is. Okay. Now, it's my honor again to invite Dr. B.K. Rana, who is the ISQA board member. It's my privilege to hand over the session to our chairperson who will be introducing our speakers, and definitely we're going to have a very, very good time here. Thank you.
Dear delegates, I'm extremely honored to have the opportunity to introduce our esteemed speakers who are internationally acclaimed as the stalwarts of healthcare quality across the world. Professor Cliff Hughes is president for the International Society for Quality in Healthcare. He is also professor of patient safety and clinical quality at the Macquarie University, Australia. Currently, he is advisor to the WHO Policy Roundtable on Quality in Health Services. Dr. Peter Lackman assumed the position of ISQA CEO on 1st May 2016. Dr. Lackman was a Health Foundation Quality Improvement Fellow at IHI and has developed the Quality Improvement Program at Great Ormond Street Hospital, where he was the Deputy Medical Director. Prior to joining ISQA, Dr. Peter was also a consultant pediatrician at the Royal Free Hospital in London. Dr. B.K. Rana is the founding CEO of the Quality and Accreditation Institute and former director of NABH India. He is a board member of the ISQA. He has played a key role in establishing the Asian Society for Quality in Healthcare, the ASQA. He is also a member of the European Pathway Association. May I now request Dr. Vispi Jokhi to please give the opening remarks for this session.
Good afternoon, everybody. I am privileged to become the chairperson of this session. When we talk of quality, one talks of accreditation. Quality and accreditation almost seem to be synonymous. But the question that always is there is, are we doing accreditation just for the sake of accreditation, or we are doing it for a purpose? And if the purpose at the heart of all our healthcare endeavors is the patient, and if the patient safety and the patient outcomes are affected by accreditation, then quality and accreditation is worth it. And that's the reason why this session assumes a lot of importance. And we've come a long way from the time when, we in India were not very quality conscious, and we typically looked on quality as something which is difficult to achieve. We want to achieve it. We want to achieve standards which are equal to international standards. I myself come from a hospital, which is Masina Hospital, which is almost a century-old hospital, the oldest healthcare institution in the city of Mumbai. And we face the challenge of ushering in quality in our own institution. So we have got a lot to learn from this session. Thank you very much for inviting me to be the chairperson. And with this small few opening remarks, I invite the speakers to start their deliberations. Thank you.
Thanks, everyone. Could we have the first slide? So just to say how we're going to work it today, they're not 3 talks. We've integrated everything, so we'll be changing slides every now and again, as long as I remember which time to stop talking, but they'll remind me. So the question today is really about this query. If you do accreditation, does it make a difference? and we hopefully are going to be able to answer this question. There's a bit of audience participation, so we're going to start. We'll see what happens. Yeah, okay. The first thing I just want to tell you about ISQA, we are a non-for-profit organization made up of members around the world, and this is our mission. And I think that many of you would be able to agree that improving healthcare around the world is the most important thing. And we're very keen to be here in India, seeing that a good proportion of the world's population live in this country. So if we can make an impact in India, then obviously it's going to make an impact worldwide. I mentioned earlier we have conferences. That's one of the things we do. And more importantly, we have a learning and knowledge network, which is a very cost-effective way of learning about quality and safety from worldwide experts. And that's one of the big things that we offer online, so that's available for people who want to join that. We also have a network, and I'm going to ask Cliff to talk about membership and the importance of membership.
Thank you. I'm not sure if you understand what a membership organisation is. It's one that you can belong to. It's one that you can actually own. And since ISQA was formed over 30 years ago, we've constantly wanted our organisation to be owned by those people who are engaged in patient care and in the measurement of the quality of patient care. And there are lots of ways in which you can join. You can join as an individual. Have we got one of the other slides there?
Yeah. No,
I guess.
It's all on the same slide.
That's all right. You can join as an individual, or you can join as an organisation. You can join as a group of individuals in your hospital and get some quite significant benefits, not the least of which is learning together in some of our programs. And our job is to serve the members wherever they happen to be living and wherever they happen to be working. And we'd encourage you to go onto our website and have a look and see just what the opportunities for membership really are, because then it becomes your organisation. And you'll hear us say constantly this afternoon, we want you as members of our organisation to measure and tell us how we as healthcare providers can do it better.
And one of the big things about membership is this one, partnership with patients. I think that you heard that today in the debate, which is right or wrong, but the most important thing I think in the debate is not that patients are the consumers, but they are partners. And being a partner with the patient is what we all do, and that's what we really look for in what we do. I'm going to ask BK to speak about the next big area, which we're going to be talking about today, about accreditation. And BK has got a very lot of experience in accreditation in India, so he'll take us through the next few slides.
Thank you, Peter. Thank you very much. Good afternoon, everyone. And when we talk about external evaluation, which is an accreditation network of ISQA, it's a global in presence. They have a IAP, which is International Accreditation Program Global, having a 66 organizations around the world in 34 countries. Next, please. So the network for the external evaluation and accreditation is over the world, and ISQA provides 3 accreditation programs. ISQA provides 3 accreditation programs. The program is for the standards accreditation, accreditation for the organization itself, and for the training program. So there are 3 products: standards, organizations, and surveyor training programs. And they have over 90 clients with international surveyors from around the world, 60 plus clients in 34 different countries, and you can see the presence, including India. NABH is accredited by ISQA as an organization. Hospital standards are accredited by ISQA. So we have, and this is the local presence for international accreditation program. You can see the list of whole of the different countries which are part to in IAP. And the ISQA accreditation organization, there's a list, and this list is also available on the website of ISQA. You can just go to ISQA accreditation program, and you can drill down the things, and then you can find the list of accredited organizations by ISQA, training providers, as well as the standard accreditation. And when you talk about the external evaluation by ISQA, the accreditation of the accreditation bodies, like NABH, JCI, Accreditation Canada, so there are 8 standards which are put together, which are to be implemented by the accreditation body. Like the governance, how the accreditation body is governed itself for the operations of accreditation program. What are the strategic, operational, and financial managements? Because it's very, very important that you have to have a strategy to manage the accreditation program. It should be operationally sustainable and financially viable. risk management and performance, how the accreditation organization is managing the risk, and how they are able to map those risks and manage in time to come. Human resource management, of course, everybody knows about that. The human resource is the critical aspect of any organization, including the accreditation organizations. So we have to map those human resources parameters within the accreditation organization. And then information management, how the information is collected from the providers of healthcare, like hospitals, clinics, blood banks, to whom that accreditation body is accrediting. So how the information is collected, retrieved, stored, and then further disseminated. And the surveyor management program, that how that organization is managing the surveyor workforce. We call it Indian assessors. The term used is surveyor, so it's interchangeably used, surveyor or assessors. So how the assessors are trained, qualified to conduct assessments, how the performance is monitored over the time, and they are continuing using for those assessment programs. Survey and client management, how the surveys or the assessments are managed. You have, say, 3-year cycle in an ABH, so how this cycle is maintained, how the surveillance is controlled, and all those things are covered in the survey client management. And last but not least, these are 8 standards accreditation or certification awards. So how the accreditation body decides that accreditation is granted or otherwise. What are the parameters to decide accreditation is granted or not, and how they are maintained further. I think.
Okay.
So, thank you.
So just because just let you know that every 4 years, all the accreditation bodies around the world, whether it be JCI, NABH, Accreditation Canada, any of them that you might consider to accredit, are accredited by ISQA. And what we do, we don't accredit hospitals. We go to the accreditation bodies and make sure they are meeting the standards that they've all agreed to meet, so that you can be reassured that the accreditation bodies are following the same process as a hospital will do, and ISQA is the body that does that and has an international organization, and is a council of all the accreditation bodies that meets twice a year to decide what the standards will be, and every 3 or 4 years they redo the standards, which we're doing right now. So a quick vote. I want to see how many of you participate in external evaluation or accreditation in your organizations. Okay, so it's not all the organizations. So we'll have another vote at the end to see what if any change. So basically, accreditation is a self-assessment and external review process. Usually what happens, you have to self-assess, and then you have the external reviewers to come and see whether you met a set agreed of standards. And really, this is only a part of a process. The process is to continually improve, and there's the aspiration to do better. And you heard it earlier, the idea in India would be to be the world class. In order to be the world class, you need to have standards to which you aspire, which are better than standards anywhere else. So that's really what you really want to do. The vote thing is if you, for those who have external evaluation, put your hands up again. Do you think, keep your hands up if you think it adds value to your organization? Okay, the hands are staying up. That's great. Okay, so there is value. So let's see if you're right that there should be value. Because what is the value to the organization? The value is that accreditation requires a framework of continual improvement, and it needs a cultural shift. Often organizations might wish to have accreditation because once they've got the badge, then it shows they have good quality. But that's the start of the journey, not the end of the journey. And I think that that's the key thing, the cultural shift, to realize that when you decide to go for accreditation, you're starting on a journey of lifelong improvement, of trying to be better than you were and better than you think you can be, trying to reach for the stars, actually, of high quality care for patients. So really what should happen is, I need to go back because these slides are not working, sorry. Can I have this is not going backwards. Can I go back? Okay, now go forward again. Okay. So you need standards, and those standards are generally set by the accreditation body that's coming to look at you and evaluate. And if there are standards in healthcare, you need then to decide that you want to improve, either to meet those standards or to better them. Now, usually, often, governments will set minimum standards. And most organizations who follow accreditation or external evaluation want to better the minimum standards, and they need higher level standards. And really what these standards do is help you to develop your improvement program, which goes on to continual improvement, and then you go through the cycle over and over again. So the framework that we have, which I referred to earlier, is this idea of quality planning. You have to plan to improve. You then have to have your standards. These are your quality controls and your measurements against where you want to go. Organizations need to have quality management. So it's no use just thinking it's going to happen. You have to manage it. And that's a lot of work. And we believe that the management is not the management of the quality department. It's not the management of the external evaluator or the CEO. It's a management of every employee to continually plan for quality, measure their process, and then manage the quality and move to the next one, which is the quality improvement. So this is the cycle that you need to go through if you're doing accreditation. And accreditation is part of the cycle. It's not the answer. It's only part of the solution. Then you can look at the process of setting a standard, measuring whether the standard is met, and then improving. And this is the actual cycle that every nurse, every doctor, every healthcare professional, every CEO, every management person should be doing every day, saying, are we meeting the standards, and how can we improve or better the standard? Now, work as usual will not work. So what you need to do is, this is not working. So can you go back again, please? That's fine. In order to get better standards and better improvements, you have to think differently. So you heard that earlier from Mike Wagner. It's no use doing the same thing over and over and over. You have to change the way we work. And of course, that means a change in culture. A change in culture means you have to think differently, behave differently, and you need to have active changes. And when the accreditation starts, that's where it begins. So, that's over to you. You're missing this. Got to go back one.
Let's go back one if you wouldn't mind.
Come over here.
So the question is, why do we have accreditation? Is it to be punitive, or is it to produce improvement? If you have a look at this graph, you can see that from the 1950s, there was a sudden explosion in authorised bodies doing accreditation for various people, mostly for organisational leaders or for governments. And you can see how dramatically that was, whether it was government, whether it was private, or whether it was a mixture of both. So the question is why? Well, politicians like to know they get value for money, and we'll talk about cost in a little moment. Hospitals like to know that what they're doing is being done in an efficient way. But we look to other industries and we realised that they were using accreditation as a tool for improvement. And that only works if you give the information back to the organisation, or in our case to the clinicians, first. So this is your tool. It's not our tool. When we come to look at an accrediting body, such as are listed here or are shown here, we give the information back to them first so that they can start to work on their own processes. So this is all about quality improvement. But we still don't know all the answers. And that's why we're putting this up to you today, because if you embrace accreditation and start to expand across such a large percentage of the world's population, we can start to get some comparative data on what we're doing now with what we do in a few years' time when accreditation is more mainstream. Because the fact of the matter is that there are a lot of accrediting organisations that don't actually thrive. There's some fantastically good ones, and there's some people from organisations in this room who know what I'm talking about. But not everybody is successful. The successful organisations tend to complement mechanisms of regulation, healthcare funding, government commitment and to quality, and healthcare improvement that takes place in a supportive environment. It's not a punitive process. And it's first and foremost a self-assessment. So the principal challenges for accrediting bodies are when they live in an unstable environment, unstable politically, unstable economically, or when they actually have a small market with low uptake. You don't have a small market and you won't have low uptake. So what a contribution you can make to that debate. But there are some recent trends in accreditation we need to be aware of. One of those is unannounced surveys. This is happening particularly in the UK. Sounds like a good idea. We'll become a secret shopper. That might work in a commercial world, but in a hospital world, doesn't. Sure. Okay, it's all right, I can stand here. How's that? Is that better? Okay, good, thank you. The unannounced surveys sound like a good idea, but unfortunately they tend to foster the idea that this is a punitive process. I was working in a hospital just a little while ago and they had an unannounced survey. 70 surveyors arrived to look at one hospital. I said to the lead member of that team, what would you have done if 70 senior clinicians arrived at your hospital when you were a resident? He said, I would have taken a day off. So accreditation needs to be put into a positive light where it's something for the organisation first and foremost. Patient satisfaction surveys are really starting to catch on. And we talked briefly this morning, where are the patients in a conference like this? Where are we going to hear their voice? There are a number of organisations that can help us do just that, and we need to put that into the accreditation process. And there are places now that have mandated accreditation. Australia has done that nationally. They started off with 10 standards. They reviewed those after a few years, and there were a couple of standards which were now ubiquitous. Everybody was meeting the benchmark, so they dropped those off the measurement and put others in their place. And Canada has got mandatory programs in several provinces as well. So it's gaining attention. So accreditation for quality and safety structures the quality and safety structures is more evident in hospitals which are accredited or ISO certified. There's not a lot of difference between the two processes as far as the numbers are concerned because we've got such small numbers. That's why we want you to be involved in measurement from day one. What we do know is that quality does respond to inspection. The interpretation of results across the different types of accreditation remains unclear, largely because groups like ISO and others grew up in an industrial model where they are measuring physical properties of physical structures, whereas we're talking about biology all the time. And standards themselves are ubiquitous within healthcare now, but they're often way behind the times, and they don't reflect current practice. And there is still not enough robust evidence to say that they alone will make a difference to the quality of healthcare. But as part of an integrated approach, then they will certainly make a difference. So the next question then, do you think standards reflect the safety of your service? Just raise your hand if you think that standards affect the safety of your service. Oh, a significant drop in numbers have come up this time. And that's true, because we still don't know all the answers.
Okay, so actually what we're trying to do now is look at some of the evidence on where it works. And this is really the key thing, because as a doctor, I was taught always to look at the evidence. And when I became a quality improver, my standard of what I was looking at changed because I realized there's more than randomized controlled trials. And one had to look at qualitative data, quantitative data as well. So you had to look at evidence. So when we started putting this together, we looked at the evidence in the literature to see, is there evidence that accreditation or external evaluation works? The main evidence is that there haven't been enough trials or write-ups. And what part of our intention today is to appeal to you, to the accreditation bodies and to those organizations that are going for accreditation to join in large-scale research to demonstrate, because we do know it makes a difference on feedback, but we now want you to write up the evidence. So we're going to take you through what's what we know at the moment, and we'll see what they have. So this is the section called the evidence, and what we're going to do is, in different ways, we're going to look at evidence on overall from reviews and then evidence from different countries. So Charles Shaw has done 2 systematic reviews, and what they have shown are definite. That accreditation promotes change and professional development. It has some financial impact, but you'll see it later. I'm going to say we don't really know what it is. It does lead to measured quality improvements and performance. And if the hospital is transparent and discloses its findings, it can increase credibility. But when he did this study, it was a few years ago, and patient satisfaction wasn't a big issue in being accreditation, so there's no evidence on the patient satisfaction. A second review, again by Charles Shaw and his compatriots, showed that it improves the process of care and the clinical outcomes if you look at different clinical streams. And it shows also that it can be used as a tool to improve the quality of healthcare. So these 2 studies, which are systematic reviews, are very positive. Not hard data, but showing positive outcomes for accreditation and external evaluation. However, the researchers from Australia show that one of the problems of accreditation, and I heard it yesterday as well at a number of sessions I went to, is the quality of the standards, of the surveys, and so on. We haven't really set out that if you have surveyors from one team, they have the same outcomes if surveyors from another team come. This is consistency and reliability we've been talking about. And this is a big challenge for all accreditation bodies, is to ensure that there's reliability in the assessment. And I'll give you an example of a non-accreditation example in the UK, is that Mid Staffordshire, which was referred to yesterday in one of the talks, as being one of the biggest challenges in healthcare, had been inspected, okay, they weren't surveyors, but had been inspected by the regulators a few months before and passed with flying colors. And you say, how did that happen? That they had an inspection, and they passed, yet they had a big disaster in their healthcare a few months later. So really we need to make sure that what happens after the accreditation is of a high standard every time, and that's reliability. I also mentioned that the cost-benefit is not yet shown yet. So cost-benefit of accreditation is something that we ask organizations now to demonstrate, and I think this is something that when they're re-accredited, the organizations who accredit them should be asking for the financial benefit from the process. But you have to plan it ahead of time. You have to know how much you're spending to start off with to how much you save in the next 4 years. So that's something you have to plan ahead and not in past. So, for those who are being accredited, have you noticed cost benefits for your accreditation? Hands up. Sure, we've got some hands up, but not as many hands up. And I think that's not because there haven't been, but it's because something we're not measuring overtly, which we need to do. So we're really recommending now that this is something should happen. But why should it happen? Because in order to improve, in quality improvement, the cost benefit's not normally measured. And I think that must be an essential part of all quality improvement and patient safety. And in Europe, they've recently had a publication across the 20 European countries showing the cost benefit of patient safety. And I really recommend you looking at this document, which shows that it's far cheaper to implement patient safety programs than to cause harm. And I think that's very important. So anyone wants that document, please contact me afterwards. Flip. Oh, the Cochrane Review. Oh, my last one is this Cochrane Review, which shows that one of the problems of accreditation is that governments want to use it as policy making. And the Cochrane Review shows that in order to do this, we need to give governments stronger evidence. And I think that that's our responsibility as well as yours.
So we've had a look at system reviews. We've had a look at a Cochrane survey. But we need to get more evidence. And because we've had a lot of countries and a lot of organisations that have been taking up accreditation, we've started to get some empirical suggestions that this actually works for the benefit of patients and works for the benefit of the staff and indeed for the organisation, including the Chief Financial Officer. So this data comes from Canada, which had surveyed their processes in 2011 and updated them since. And we've got Leslie Thompson from Accreditation Canada here, and our president, Wendy Nicklin, was formerly of the same organisation. We think accreditation is important. It actually demonstrates it's a very effective risk mitigation system, and all good businesses now move towards risk management as a basic governance procedure. It strengthens interdisciplinary team effectiveness because we start to get the organisation working as a team rather than as silos or individuals. It certainly improves communication because the risk management officers are coming around talking to everybody about what's happening. Are you ready for the accreditation for the surveys? It promotes measurement, and we're actually appealing to you, whatever you do, even if you don't do accreditation, and I hope you don't fall into that group, to measure what you do, because then you will know when you're doing a good job or a bad job. It also helps us develop the right sort of indicators for the improvements that we need. It probably doesn't change patient satisfaction, mainly because we probably haven't got the indicators and the right questions to put to our patients and their families. But it does provide another source of data capture from which we can triangulate the process of accreditation. And Canada concluded that accreditation process is an effective way of introducing change, but it's subject to a learning cycle. So don't just do it once, keep doing it. And institutions invest greatly to conform to the first cycle. They do it maybe for the next 2 or 3, but then they get a little bit bored. And then they suddenly realise they've got a problem, such as happened in the UK, and the wheels fell off. After 10 years, sometimes the plot's been lost. And we need to understand that this is core business. It's not an add-on. It needs to be part of the mantra of the board, of the management, of the CFO, of the Chief Medical Officer, of the Chief Nursing Officer. And to maximise the benefits of accreditation, health organisations and accrediting bodies must seek ways to take advantage of each cycle as the process develops within their organisation. We also looked at what we could learn from Brazil. They looked at 13 organisational structures to see how it was working. And they noted that there was evidence of a significant and moderate correlation between the status of accreditation and the patient safety activities, quality activities, planning activities, as well as policies and strategies. And they did notice that there was a significant correlation with accreditation and the involvement of professionals in the quality programs. We were using this bureaucratic process to engage with the clinicians once again. The correlation between accreditation status and patient involvement was again significant but weak. So we need to work harder on engaging with our patients, and we talked about that briefly this morning. They also noted the impact of accreditation on the financial results was not confirmed because they couldn't get enough information to determine its relevance. But they did recognise the need to invest in the process and therefore start to measure. And they finally said that the impact of accreditation is mainly related to internal processes, the culture, the way the organisation works, the training, the institutional image and competitive differentiation. All good reasons why we should go ahead. And then moving to the Middle East, we had a look at Lebanon. And there, it was the nurses who said hospital accreditation is a good tool for improving the quality of care. So as well as the board, management, CFOs and others, the nurses at the bedside are saying this tool improves the quality of care in our environment. Does it in yours? Let's start measuring it to find out. And they also noted that in order to ensure that accreditation brings effective quality improvement practices, there is a desperate need to assess quality-based programs on the patient outcome indicators. It's not sufficient to have it as a process tool, it must be an outcome-based tool. And in South Africa, there were 10 hospitals who were involved in accreditation programs in 1998. This is not new data. There were others that served as a control. And so we had a bit of a prospective program, maybe not level 1 evidence, pure and simple. They noted the improvement on the intervention hospitals relative to controls was statistically significant and seems likely to have been due to the accreditation programs that had been laid out in the intervention hospitals. And with the exception of nurse perceptions of clinical quality, the independent research team observed little or no effect on the intervention of the 8 quality indicators. It's a very negative way of saying the nurses actually recognised that there was improvement. They obviously were half-empty people when they wrote that recommendation. The practical implications in South Africa were that facility accreditation programs were successful in increasing public hospitals' compliance with the known and agreed standards across the public system. But additional work is needed to determine if improvements in their structure and process standards would result in improved outcomes. I'm not sure that they got that quite right, because what we've been saying is you've got to do something about process, but you have to do something else, something in addition, about outcomes. I'll hand over to the expert on India.
Thanks, Cliff. Thank you very much. Thank you very much, and I bring back you to India. Most of us sitting here from here, and a couple of you are already accredited by NABH, which is the national body here in India. As we already talked about, a couple of countries, Lebanon, South Africa, Canada. Similar situation here, but we do not have much structures data with us. And this is the situation what we are trying to predict at the moment is that whosoever is accredited may be familiar with that you as an accredited hospital by NABH is required to submit every quarter the data on these indicators. Am I right? Yes. So you submit that, and what you get out of that is the analysis, conclusion, some benchmarks, some statistics to say where you are amongst the hospitals which are accredited and using. So these are the parameters at the moment I put on the slides. So data on these indicators, if you look at, is for quality improvement, looking at the purpose of accreditation, the process of improvement, process of patient safety and quality. However, we could not draw much conclusion out of the data because at times data is not consistent. Data is too varied, starting from 0 to 100, and no systematic study conducted as well. So these are some of the regions that we are not able to bring out as the benchmark in Indian history. For example, if we say one of the infection rates, infection prevention and control, what is the infection rates of, say, surgical site infection in your hospital? There are 300 hospitals accredited and they submit data to NABH. And can you guess what is the range? It starts from 0 to, say, 16 or 20%. So I'm happy to say that, yes, it's good to have 16% and 20% to accept. Not clinically, but how you accept the data is 0%, you know? Surgical site infection, 0% reported by many of the hospitals. So you have the 0%, you have 2%, 3%, 6%, 20%. So how you analyze, you know, if you apply a statistical tool, even the outliers are too much, you know, if a negative side or positive side you take out, even then you have, say, 5% to 15%. So it's very, very difficult, and then NABH is trying hard to work out some statistical processes to refine the data to come out at least some of the processes which we can pass on to the hospital, say, hey, you are good. So we are trying to build up on the national median, the state median, and the hospital, because, again, the comparison can be done on similar like apple to apple, oranges to oranges. If a multi-specialty cardiac care, neurological, orthopedic, and comparison with the general hospitals, you can't do injustice with that. So there are a lot of challenges for comparing data, and that's the basic reason we do not have data for Indian hospitals, which proves, which provides an evidence like Peter and Cliff was talking about, is evidence for whether accreditation improves patient care, quality, safety, and so on. So there is no scientific evidence collected through systematic studies, so we have not done that as well, that we have institutionalized an independent, scientific, evidence-based study to carry out this type of process and come out with the data. However, there is no denial that maybe what we are talking to say and saying that there is no enough evidence that say that accreditation improves quality, safety, and so on, because there is no systematic study done. But, however, there are circumstances, chances in a person to look at the data which definitely say that the regulatory compliance goes on the hospitals. Because that's one of the mandatory requirements for accreditation, starting from biomedical base to radiological safety. And when you comply to the regulatory requirement for at least these two, I see that patient care and safety goes up. Awareness about the patient safety and quality amongst care providers, if you think about 10 years before, we were not knowing what we are talking about today. Quality, safety, improvement, medication errors, so and so and so. Basic practices to prevent harm like injection safety, medication management, and so on, we are talking about today after 11 and a half years of inception of NABH in India. So what I want to convey over here is our 3 slides is, though no systematic study, but there is the process of assessment which looks at different processes in the hospital, which can say that yes, there is a benefit for accreditation if you adopt to go for. I think, not moving. Okay, so one more slide for nursing care, and nurses amongst here definitely would agree that nursing care has gone up. Different processes involving nursing care is starting from noting down the clinical symptoms and the doses, medication, and chart, everything goes up. Diagnostic safety, including the lab safety and the radiological safety or imaging safety, really has gone up. And definitely, amongst the people who are coming for treatment, the patients, their awareness also goes up. They started asking questions, why you are doing things, why you are doing things, how you are doing this. So definitely it's a win-win situation for everyone, for the accreditation body, the hospital, the care providers, and the receivers, the patients. Over to you, Peter. Thank you.
So we just got 1 or 2 slides, and we're going to open up for questions for the last 15 minutes. So we've spoken about countries, just to show you that if you look at accreditation of particular patient outcomes, whether it be in, this was in a renal transplant center, next one was on mortality and readmission rates, and the next one was on, this is accreditation with, about colonoscopy, about processes that showed improvements. So in summary, basically, accreditation is part of the answer. It's not the answer. It's part of the answer to improve healthcare. There are lots of different ways of doing external evaluation. It could be regulatory, where the government comes. It could be a quality improvement process. It could be part of voluntary, be mandatory. Each alone is not the way to go forward. It has to be part of an overall desire to continually improve, and accreditation can be the stimulation to improve outcomes. The critical factors are collaborative, valid, and well-used relevant standards that are continually improving. Even now, having patient involvement in the development of the standards is considered to be something that's very important. It's very important that the healthcare professionals accept the standards and they believe that they're relevant. Because if they're not relevant to the healthcare professionals, then you're not going to know what you're really measuring. Healthcare organizations need to be capable to embrace accreditation and evaluation as part of their program. And we should always remember that we need to align them with regulatory initiatives. So it makes sure that the standards are not opposing what the regulation says. It should be improving on the regulations. But the final call for all of you. We have been quite open and honest here, saying that we believe accreditation and external evaluation is a valid part, an important part of quality improvement and improving healthcare. However, we need more evidence, and we're appealing to the accreditation bodies who accredit organizations and to the organizations that are being accredited to start collecting data, to start publishing the data, and to be part of a big trial. Now in India, as you're embarking on expanding accreditation, external evaluation, there is an opportunity to get great results, whether it works or not, but to get great results of research on a large scale. We are open for questions now. Oh, one thing, would you now consider an external evaluation program? Hands up or down? More hands, I think, yeah. Okay, oh, well, no questions, but I hand over to our chairs. Thanks very much. My last quote you can read while our chair's speaking, because this is really about planning.
Yeah, for paucity of time, we are not entertaining questions, but you have an interactive question mechanism, so you can put your questions and they'll be answered. At the beginning of this session, I think the audience was intrigued by the question. It was almost like self-evident. Accreditation seems to be an important thing. In a varied healthcare scenario in our country where there are so many varying standards, probably there could be a case for a minimalistic approach as against an approach where you need to do accreditation for improvement. I think as organizations, we've come a long way from that. We want to go for accreditation to improve our standards. And the ISQA validates NABH, therefore NABH is an accreditor of accreditor. ISQA becomes an accreditor of accreditors. So in effect, it is an important thing for us to achieve these standards. The most important thing that came out of it is that we need to get the patient's feedback on accreditation. That is something which I think is a revelation, and that's something which we did not realize before we started this session. And I think an honest collection of data, an honest evaluation, and using accreditation as a tool for improvement rather than just the sake of accreditation is important. And last but not the least, I think I'm intrigued by the fact that there is a cost benefit to accreditation. As soon as we know there is a cost benefit to accreditation, the acceptance of accreditation from our principal owners becomes stronger. The cost of accreditation which healthcare organizations have to bear will be a cost which is worth bearing and worth going ahead. Thank you very much, all the speakers, for an excellent session. And if I think ma'am wants to have a few more comments.
To the esteemed speakers on the lighter side, I would like to mention that accreditation amongst its various benefits has a benefit of unifying the organizations themselves. While doing accreditation, different teams, cross-functional teams come together, and you not only unify within the organization, but across the globe also. As in this conference, we're all connecting with each other for benchmarking best practices across the globe. So that is one of the benefits that we should add up to. And teamwork is so important for achieving patient safety and quality. And I'm not trying to be poetic, but I would like to mention here that improvements are always at the individual level. But when we are talking of progress, it is always collective when we are all together. And when we are wanting to achieve excellence and quality, we all need to be joined together in a unified manner. Thank you so much.
And you can always contact us on these contact details, any of us, and we're happy to answer your questions if you've still got questions, or follow us on Twitter. We'll answer it there. Thanks very much.
And for the audiences, sorry we are not able to entertain questions, but you can use our patient safety app and put in your questions, and we would get back to you.
And you may not download emails. Anytime you can send an email or Twitter. We will be happy to answer your questions and provide you more information in case you are interested to get more and deeper information on any of the topics we just talked about. So thank you very much for your time.
Thank you. Okay. Please do not move out of the room, because if you do so, you're going to miss a very important session which is lined up next in few minutes, which is very, very critical for patient safety. Yes, we're going to talk about infection prevention and control. So our next session is going to be on infection control, medical travel, prevention and control of emerging infectious diseases. We're going to start in just 2 minutes. Good afternoon once again, and a warm welcome once again on behalf of 7th International Patient Safety Conference. We're going to have a very important discussion today on infection prevention and control, medical travel and prevention and control of emerging infectious diseases. To talk upon this session, we have very eminent people among us. This session will be chaired by Dr. This session will be chaired by Lieutenant General Dr. V. Ravi Shankar, who is the Chief Operating Officer of Lilavati Hospital. Sir, may I request you on stage? Sir has served in the Indian Armed Forces Medical Services for 38 years. Sir has risen to the highest 3-star general rank and has been awarded Vishwat Seva Medal by the President of India for his meritorious services of exceptional order. He is currently working as Chief Operating Officer and Consultant Cardiac Thoracic Surgery at Leela Hospital. A very warm welcome, sir, and thank you so much. The next person who's going to chair us is Dr. Tushar Parmar. Dr. Tushar Parmar has done his MD in internal medicine. He's a consultant critical care, and he's also a member of European Society of Critical Care. Thank you so much, sir, for coming here. Now I would take the privilege to invite the speakers for this session. Dr. Geeta Nataraj, who is a microbiologist, KEM Medical College and Hospital, Mumbai. Thank you, ma'am. Mr. Tim Gallup, Advisor for Discipline, Priv and Director, TIGMAT Consulting. Thank you, sir. Mr. Tyagarajan Thanvan, who is the founder and CEO of Tides Institute of Health and Medical Sciences. Thank you, sir. I would hand over the session to the chair now.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank Apollo Hospital Group and Dr. Trivedi for inviting me here. As you know, Dr. Trivedi has been one of my predecessors in Lilavati Hospital, so I think the bonhomie stands. And Dr. Tushar here is also ex-Lilavati Hospital. It's my pleasant duty to introduce the 3 speakers today. Dr. Geeta Nataraj, she hasn't given much of a CV here. I find it's a couple of lines. She's a microbiologist at KEM Hospital, Mumbai, Secretary, HISI, Mumbai chapter. And she is actually the professor and member of the Infection Control Committee who plays on the threat of tuberculosis for the healthcare workers. We have Dr. Tyagarajan Thanvan. Started his career in 1998 with experience of more than 15 years in dialysis, including 10 years of experience in teaching. And he's from the Sri Ramchandra University, that's Chennai, in renal science and dialysis technology. He's the founder of MSc, honorary member of MOH of the National Task Force, curriculum designer, board of studies at various universities, which includes the KMC Manipal University. And he's also an examiner for many universities. He's been a guest speaker at many international and national conferences, also published a lot of books. And he's been richly awarded for the work that he's done. Welcome. Mr. Tim Gallup, welcome, sir. He's an advisor, Dispolin, InPrev, and director, TIGMAT in Belgium. Tim is regarded as a global expert in the field of infection prevention and sterilization. In his last role, Tim was responsible for the global technical support and regulatory services and has been working in the medical field for more than 40 years. He's been a member of the Dutch Norm Group from the day of foundation in 1980 and has participated in the German DIN and the French AFNOR. We will listen to the speakers, and after that we'll have a discussion and try to summarize what they're going to talk. May I call Dr. Geeta Nataraj first, please? Thank you.
Good afternoon, chairpersons, distinguished faculty, and friends. Some of you I know, many of you, almost all of you I don't know, but that doesn't matter, I guess. So I was assigned this topic just a few hours ago, and looking at that topic, it's something like vertigo prone. So just keep that aside. And how does this move in front? Can I have the next slide, please? And can you just tell me how this operates? Okay, so I'm just looking at it in just taking two situations out of this. One is when you have to receive and treat patients who probably come from areas which are prone or which are undergoing an outbreak of specific infections with high morbidity and mortality. And the second thing is when you think you want to travel and you want to know whether it is safe to travel to a given destination. So this is what I conjured in the short time that we have. I know that I have to wrap up very fast. So pardon me if you feel that it doesn't work still. So why is there a need for caution? As healthcare providers, I don't know how many of you are clinicians, but I believe there are a whole lot of you are nurses. Yes? Yes, and there probably are a few clinicians here, and maybe no administrators around. So the need for caution is because you as healthcare providers may consider yourselves as gods or semi-gods, depending upon which discipline you are in, but you aren't. You are as susceptible to infections as these patients who you have to take care of, right? And if you want more on this, then just look at what happened during the recent outbreak of Ebola. So in terms of Ebola deaths, just look at what the scenario was. That you had more number of healthcare providers dying of Ebola than you had patients who died of Ebola, not in terms of numbers, but in terms of proportions. And that happened in all the 3 Central African and West African states that went through this epidemic or pandemic as it stopped short of. The other thing that I have noticed during these outbreaks and when you have these newer infections coming in, I just want to talk to you, I think I don't have too much time. So when these newer infections come in, all the private hospitals put their hands up saying that, oh, we don't have this, we don't have that, so we can't do it. But the public hospital, like the one that I come from, are expected to contribute and set up measures to prevent and control the spread of these diseases, and that's a fact. We were involved in swine flu in 2009, 2010. We got involved when there was a suspected MERS outbreak that was happening in Middle East because a lot of our people go there and a lot of people come back. And we were also involved during Ebola when we had to identify places, identify and implement infrastructure, manpower, etc. So there's only one slide henceforth that I want to share with you, and that would be what we need to do in terms of implementing. You can go through this presentation, I have left it here. So what do you need if you have to prepare for being prepared? A, understand what the disease is all about. Okay, which means how do you suspect that this patient is going to be suffering from this disease? So starting with clinical suspicion. Have diagnostic support, okay? So you have to start from there. Understand what the disease is about. Understand what the disease-causing agent is all about. And when we talk about the disease-causing agent, in terms of infection control, what's the most important thing that we need to put into place is what is the mode of transmission of this agent. Simply stated, that's what infection prevention and control is all about. A majority of the diseases, I skipped a few slides there, a majority of the diseases, if you see, or almost all the diseases, are either transmitted by A, the airborne route, or by inhalation, B, through contact of droplets or other secretions, either directly or indirectly, and 3, you do have outbreaks of cholera, so that's by ingestion. So these are the primary modes of transmission of all these fancy diseases that come into our country or go out of our country, and these are the things that you need to think of before you implement measures to prevent the transmission of these agents. If you prevent the transmission of this agent to the next patient, you are preventing it to yourself also. Am I right or am I not right? Yes. So let's talk about if you have an organism or if you have a contact which by inhalation, contact, ingestion, these are all that you have to have. First is be aware and be vigilant. Okay, so you must identify a person, you must have a team. You have rapid response teams, you have emergency medical teams. So one of those teams should be assigned with the task of looking at newspapers, looking at media, to find out if there is some kind of an outbreak, disease outbreak with a high morbidity mortality from where people are likely to get into our country. Plan for what you need to do and implement certain measures. So under implementation we have, first is look at the infrastructure. During the swine flu outbreak, none of the private hospitals put up their hands to have patients enrolled in their particular hospitals because they did not have the infrastructure. So what is the infrastructure that you need? You need an infrastructure that is very simple. You need an infrastructure wherein the organisms are not going to be transmitted primarily by the mode of droplets, right? That's how influenza spread. So that's not something that all of you don't have, you all have it. But there was this misconception that during that outbreak, there was this component of airborne infection. So everybody was looking at a negative pressure room, a negative pressure ward, how many patients can I take? I don't have that capacity. There is recirculating air conditioning and therefore I can't do it. All we needed at Kasturba Hospital was an area which is large enough to accommodate about 30 patients with well-ventilated cross ventilation and with exhaust fans. That's all we did, and that's how we took those patients in during the initial outbreak. Subsequently, we know that all the hospitals are admitting these patients without much ado, okay, because by now we are more well informed. So over a period of time, we have learned that it's not necessary to have negative pressure isolation rooms where the mode of spread is simply by droplets. Yes, we do need to have negative pressure isolation rooms when we are talking about multi-drug resistant tuberculosis, when we are talking about extensively drug resistant tuberculosis, when probably we are talking about chickenpox, measles, all these things that are either obligate airborne or opportunistic airborne or potentially airborne. So look at the mode of transmission. And if there is a mode of transmission that is airborne, then you need these negative pressure and all that stuff, okay, individual isolation rooms. But when Ebola happened, there was something more that we needed to do. Yes, the disease is transmitted by contacts. Yes, the disease is transmitted by droplets. But the disease-causing organisms are so many in number. They are not just found in blood and body fluids. They are also found in secretions and excretions. So in short, there was bugs everywhere if the patient walks in. So what do you need? Here also you will need individual isolation rooms, right? And Ebola is one disease where biomedical waste management is more important than any other. So you cannot admit patients with viral hemorrhagic fevers, which are very fatal, not just to the patient, but once it gets transmitted, without having local treatment facility. All this while we wrap it, bag it, yellow bag, red bag, and send it to the biomedical waste authorized person for treatment. But in this case, they have to be autoclaved first before you give that back to somebody else. There has to be training. And it's only during Ebola that we realize that people do not know the simple things from the personal protective equipment. They all knew that they need to be covered, but they did not, please stop me when it's 10 minutes. They all knew that they need to be covered, but what they did not know was what to wear first and what to remove first. What they did not know was, so this kind of a training is not just sufficient to complete with the training. You also have to demonstrate that they are proficient in wearing the personal protective equipment, because all said and done, we know that there are 3 levels of control. I don't know if you know it, so I'm sorry if I'm using that phrase too often. There is something called as administrative control, there is something called as environmental control, and there is something called as personal protection. Administrative control and environmental control is somebody's responsibility and accountability, not yours. But you are responsible for yourself, you are responsible for the next patient, so the least you can do is take care of the personal protection. So the personal protection is something, the key for preventing the spread to yourself is in your hands when you have the right personal protection, and administrative controls and environmental controls can only achieve so much. They maybe can achieve a lot, but they can only achieve so much. So people need to know how to wear personal protective equipment. People need to know how to remove personal protective equipment, and people need to know what to wear first and what to remove first. That's equally important. And you have to see that you demonstrate their proficiency in doing all these activities. And when you have a ward that is assigned for a disease like Ebola, you need to have a supervisor who will monitor whether they are wearing things properly and whether they are removing things properly. In our influenza wards, in our so-called Ebola wards, fortunately, we never had a patient. We also need to maintain a logbook. I don't know how many of you maintain a logbook, but it's important that you need to maintain a logbook. So that was just in short what I wanted to share with you. I would have loved to share all these things with you, but from 15 minutes, it's gone down to 10 minutes. So this is like the Ebola isolation ward, where you can cohort the patients, but definitely you need a changing room. You need a disinfection room. You need a disinfectant everywhere. So the other thing that you need to know is duration of isolation precautions. How many of you are reading newspapers? Are you looking at something that's happening in Australia? What's happening in Australia? They are having an epidemic of seasonal flu. Why is there so many cases? More than 1 lakh confirmed cases of H3N2 influenza is happening there. That's the seasonal flu variant, right? Influenza A, not the H1N1 that we have as the seasonal flu. Why is that happening? Because patients do not know that even if they are feeling well, they are infectious. They go back to work, kids go back to school, and then they spread the disease. So how long should the isolation be is equally important as what the organism is, how it gets killed, and how it is spread. So prepare for the 3 modes of transmission, which I said was inhalation, ingestion, and contact. Prepare based on 3 levels of controls, which is administrative controls, environmental controls, and personal protection. In addition, we know that there are situations where you get dengue, where you get malaria, so therefore have vector and pest controls in place, and all infectious agents can then be taken care of if we look at it like that. And finally, the key to control in terms of preventing the transmission to yourself is by using the personal protective equipment as and when needed, as and when required, but use them effectively, right? By using them effectively, what do I mean? I have an N95 or a powered air pressure. See that it fits you well. See that what you're using to cover yourself covers yourself totally and completely. See that you're not tying things in front so that there's a gap in front. See that you tie things at the back. See that you wear a shoe cover. See that you are well protected, because your health is in your hands. And if you're going abroad, don't forget to get vaccinated. We have this fancy of, sometimes we go abroad just for the animals, exquisite animals or whatever you call endangered animals, to come in close contact with them. All of them carry some kind of an organism which is easily spread. So these are zoonotic transmissions, unusual infections for which there might be no treatment. So be very careful about that, and always have safe food, safe water if you can get access to it. These are the references for my presentation. All of them were interesting, and thank you so much for your kind attention.
Thank you, ma'am, for your presentations. I would like Mr. Tim to come over and present us how surgical dreps and gloves should be used. Thank you, sir.
Thank you very much for the introduction. Is it working? Because I'm not one which can stand behind these. I have to cut down on my presentation due to the simple fact that we run out of time. However, I have to make my points clear, so I will skip my introduction. Now, it was asked to talk a little bit about regulation. Now, as you can see here, there are all over the world, there are directives, regulations, and guidance documents. And for instance, one of the things I would like to say here, that from 2007, I'm now visiting India, and in India, I have seen one enormous thing. It's changing day by day. You walk outside and you see the metro and the underground and all those kind of things growing very fast. It's getting cleaner in India, but I think as well, no, that's true, that's my observation, and I think as well, you have the opportunity not to reinvent the wheel, but to use those standards and laws and norms and directives which are already published. And that is one of the things you're going to have as of the 1st of January 2018. Not going into much detail. But we have, in Europe, we have the Medical Device Directive, and the Netherlands was the first country all over the world which had the medical device directive. And why? Because 12 patients died due to the fact they got a non-sterile fluid injected. And at that moment of time, the decision was taken, we are going to regulate, we write standards, etc. Now, I'm talking about product standards. I'm talking about medical devices. I'm talking about all different kind of things. And for instance, one of the standards in Europe, EN 13795, is a standard for surgical drapes, gowns, and face masks. Now, there is here the EN 149, sorry, I make a matter, the 14683, but that is written under this document. So there is a standard for surgical face mask. And this over here, and I don't know how to do this, but, and I'm not going to touch it, but this is a regular surgical face mask. Now, a surgical face mask does not do a thing against viruses. And a lot of people are still walking outside in the streets with a surgical face mask. And if I'm right, there are even 2 plies instead of 3 plies. Well, 2 plies, you might as well put nothing or walk naked into the OT. Now, the AMI has a document for surgical drapes and gowns with 4 classes in there. Thank you very much. Pointer. This is wonderful. Now I can do my job. And we have here as well the respiratory devices, which will filter very small particles and viruses. So CE marking, you probably all have seen on imported products that there is a CE mark on it. I want to make clear that that has nothing to do with quality. Like the previous speakers were talking about quality, it is only that the product will comply with the minimum essential requirements of the regulations of our medical device directive. So if we are talking about sterilization processes, we have validation standards. So respective companies who are selling sterile medical devices into your hospital, they have to use standards to prove compliance with. And for instance, for ethylene oxide, it is ISO. You have one for steam and you have one for gamma radiation. Now, we have as well regulations or standards for sterilization packaging material. Well, we don't call it sterilization packaging material anymore. We call it now sterile barrier systems. We wanted to have the level up of the packaging material because on the CSSD, Central Sterilization Supply Department, they are always considered as the dishwashers and the packaging area where they make nice Christmas presents. Well, it's nearly Christmas, but it is a fact. And it is much and much and much more than that. So we have the 868 2-10 series. I've been the convener, the president of that working group for 25 years. Yes, that's why I have become so great. Thank you. And we, on an international base, because you might say, well, why do you start with part 2? Because there was a part 1 as well, general requirements, and that has been taken over by the ISO working group and was implemented by the 11607. So it's 2 parts. One is the validation part, which is of extreme importance for hospitals and industry. And then you have a document, which is this one over here, 16775. That is a technical specification which will give you guidance, a help to be in compliance with 11607. And all these standards have to be reviewed every 5 years because we have nothing to do. if we now look into the OR and OT, then there are all kinds of products made of nonwovens. So we have the myostent cover, surgical tape, surgical gown, drape, and sterile systems. Now, what does the medical market need? Well, I think if we have the wound of the patient, and we have the patient himself, and we have the staff, we have to protect the staff from the wound, or liquids, or whatever, the patient from his own wounds, and we have to protect the staff from the patient. So this is very simple, very fast explained what the meaning is of, and that could be done, for instance, by an impervious product. Now, there are benefits, and when I'm here in India, it is of an extreme importance that the costs are not too high, because your medical system is working in a totally different way than what we have in Europe at this moment of time. So we want to have reduced cost, less risk, infection prevention. You will never hear me talking about infection control, because if you are talking about an infection control, it means you are too late. You have to prevent infections. Time saving and create flexibility. So yes, there are a couple of things which are extremely important with surgical drapes. You have an area which we call, it's the incision area, and that is an area which should be completely closed, so you should not have any strike through. So we need a high barrier protection, wet and dry. And let me honest to you, all those people who are using textile, conventional textiles, they are working with products which are no bacteria barriers, not in wet and not in dry conditions. You might as well put nothing on. And I'm not joking. And again, that means we don't reinvent the wheel. There are enough publications to prove that. Because I'm of the opinion that every single person who's selling in a hospital has to prove its claims. And let me not go in all those. So we have all kinds of things. We have absorbents, we have liquid control, we have customized packs to meet individual requirements, ease of disposal, and you can see here, for instance, that if you use ordinary textile packs, you use much more space in your hospital than when you use single-use draping systems. And I would like have gone in more details. And then we have an area. We have the gown, the surgical gown. Now, the surgical gown, where we talk about the sterility, is from shoulders to table level and the arms. Even when the whole gown is sterilized, we consider the back as being unsterile. Again, please conclude. I can't yet. I'm sorry. I didn't drive and travel 10,000 kilometers to be pushed away in 5 minutes. I can't. I'm really sorry. I'm already going so fast that I don't even know that I'm breathing at the moment. So availability in the now I will go faster, you know, that they can read as well. So I am of the opinion that respected companies here in India, they use as well international and standard rules and standards. Secondly, medical fabrics are sourced from the best manufacturers all around the globe, which are used all over in the world. And regular tests are done, like cytotoxicity, skin irritation, bioburden, and sterility tests. Now, if I'm talking about skin irritation, I don't want to have a gown where I have to scratch all the time because it's, you know, it's terrible. Hey, do you recognize this as you're a surgeon? No, but it is happening. And then India is under one of the lowest cost of production in the world. And I have said the last 10 years, I'm out of breath. in the last 10 years that India will be the country of the future. You will take over from other countries in this world. Guess what? This was in the newspaper this morning. And what does it say? India will soon rise higher than China in global economy. And I am proud to work with people like this, and that we can fight for the rest of the world and supply the rest of the world with good medical devices. And yes, this is available as well in India, and I was so proud I could take a picture of it. Now, fundamentals of aseptic techniques. I'm saying only one thing. Go back to basics. This is in the times from 45, 50 years ago. Davis and Gag made a movie talking about aseptic techniques with red colored people in the movie and blue sterile and red unsterile. And there are so many things in here, we can still use them after 50 years, 100 years. Nothing changed. One thing about single use is stop reusing single use. It's dangerous. Single use is not made for re-sterilization. You cannot clean it. You cannot disinfect it. It is impossible. Do you want to have a dirty instrument inside your body from another patient? No. So I don't either. Because I will sue you. And that's not a joke. So this is important. Waste. We're always talking waste. But if we use waste in such a way that we can recuperate the energy for other things, hospitals generate only 0.35% of the total waste of the whole country in Europe. Non-woven single-use systems account only for 1.2% of this 0.35%. And if I take the total in non-wovens of this total, then that total, you know, that's statistics. I hate them. It is 0.0042% of the total waste. So I would say, don't wait, do it immediately, and change to single-use medical drapings, and because that's your security and the patient safety. Economics. I'm not going to more in details, but I found a medical pair of scissors cutting a $100 bill, and you will cut cost. And I have to go faster because they're getting angry with me. So we have a lot of reason to say that it is cheaper and that you have always the same quality. You have a bacterial barrier, wet and dry conditions. And my voice is going as well. My God, how am I going to explain this at home? Let's not forget we are talking about the safety of the patient and the staff today. Not only anymore and any longer about the patient itself. That was different several years ago. But you said it, and I fully agree with you. The people working in hospitals have to be better protected. Much better protected than today. Whatever. So, I heard this one as well. The chain is only as strong as its weakest link. Okay? So, you are all part of this chain. Not even one person who can say that he is not a part. Now, providing quality, that costs money. Yes, I agree. But failure providing quality costs a fortune. And where can we get money back? It is from infection prevention. Reduce the cost of all those infections we have. And don't worry, sir. It is not only in India. It is around the whole bloody world. But if I go to a surgeon and I talk with him, he says to me, oh, no, I've never had any infections. No, no. Why does the European rate go up? Why is the American rate going up? Where is it everywhere the same in the world? So thank you very much for your attendance, and I couldn't do it faster.
Thank you, Mr. Tim. It was a very educative and very interesting talk by Tim. And all of us couldn't agree more than what he said about single use, the asepsis that you should provide in the operating room. I'll request now Dr. Tyagarajan to come and talk to us. We just heard about single use. I'm sure Dr. Tyagarajan is now going to talk something about reuse, because there are certain places where we know world over certain items are reused, and let's hear from Dr. Tyagarajan.
Thank you. Very good afternoon to everyone. It's a wonderful presentation from Mr. Tim. He covered whole stage. So anyway, I'm not going to do in such a way. So it will be very difficult for me. Today the talk is on a dialyzer practice across the world, its application in India, and it's time. Can you set me the time for me? What is the time limits? And in India and its impact on foreign medical tourism. Yeah. So the objective will be on reprocessing technique and single-use dialyzer and usage technique, and environmental and economical concerns of dialyzer reprocessing, and effects of reuse and criminal liability, and SWOT we will be analyzing on the talk. Okay, previous slide. So when you're talking about a reuse of dialyzer, when we take a new dialyzer in the dialysis unit, it is a long step process where we will need to do a lot of steps, which includes start from the pre-processing, and you have to enter all the data, including the place and storage. It's most important thing. Along with we have to document, once dialysis is over, we have to do the recirculation process, and then we have to store the dialyzer. Such a huge step, we have to do it when we want to go for the reprocessing of the dialyzer. When you're going to do with a single-use dialyzer, it is a basic step. Take out the dialyzer, use it, and then we are just discarding. That is the steps between the reprocessing and the single-use strategy. When you're looking into the clinical fall of a reusable dialyzer, it is a potential for bacteria and endotoxin contamination of the dialyzer, and the potential transmission of an infectious agent from one dialyzer to the another dialyzer during the reprocessing techniques, and the multiple dialyzer reprocessing declines the uremic toxins, that is a clearance level will come down, and even we have to keep it a dwell time period of nearly around 24 hours, and there is a high infection rate and anaphylactic reactions are there with the dialyzer. The environmental concern, as still they say, is that when you're talking about a reused dialyzer, reduce the amount of a solid waste in landfill. But if you go in depth about a reused dialyzer with a single use, where the best reused, but the reused dialyzer increase the biohazard waste, and also the reused chemical